Welcome. Hopefully everybody's having a great meeting so far, and welcome to our Venous session. Today we have a fantastic lineup of speakers and panelists as part of our venous disease session. And I'm very excited to be here with Dr. Deeb, who's my co-moderator. And so with that, we'll get started. So first, it's an honor to present Dr. Carman, who will be presenting her talk on lower extremity edema.
All right, good morning. I want to thank the organizers for the invitation again this year. It's always a great meeting. So I don't have any disclosures related to this talk. I just want to start with a little bit of background. Edema, what that means is we have excess tissue fluid. That doesn't necessarily equate to intravascular volume. We don't necessarily manage it with diuretics or diuresis. And when I think about edema, I think about it in managing it as form follows function. So there are 4 things that we have to pay attention to: central venous pressure, direct venous pressure within the venous system, what goes on at the endothelial membrane, and the calf muscle pump function. And then how we clear edema from the tissues is through the lymphatics. And there are 3 ways lymphatics fail. One is if we have too much fluid there with normal functioning lymphatics. The second is if we may have the right amount of tissue fluid, but our lymphatics aren't working. And the third is a combination of the 2. We're making too much, we're not able to clear it, and therefore it gets left behind. And understanding those 2 pieces of pathophysiology are really necessary to better evaluating and optimally managing swelling. So what we're talking about at the end of the day is how do we create what we call ambulatory venous hypertension, right? So we have too much venous pressure. And you can see on the right-hand or left-hand side of the slide, there's a number of different ways we can do that. I'm not going to go through each of these. I want to get to our case a little bit. So our first case, I have a 67-year-old man who comes into my office with bilateral lower extremity swelling and weeping. Now, he doesn't have true ulcers, but he is weeping that tissue fluid or lymphatic fluid through his skin, and this has been going on for a couple of months. His right leg is a little bit worse than the left as far as the weeping, but they are equally swollen. He has relative foot sparing, although I'm sorry you can't see his foot in this picture. There's no overt lymphatic changes in the dorsum of the foot or in the toes, i.e. he doesn't have a dorsal hump, there are no squared toes. What you can see is he's got extensive hemosiderin staining, he's got lipodermatosclerosis of his skin is very taut, very shiny, and he's got a lot of swelling. So his pertinent history is that he has sleep apnea, he is not using his CPAP, he is obese, he denies a history of heart failure, but I have no echo on the chart to necessarily identify what his right side or left-sided function is. He was previously seen and followed at another institution because this is not his first episode of this. And he was diagnosed with varicose veins, venous insufficiency. He actually underwent RFA ablation, closure of his saphenous veins, and sclerotherapy in 2020. At that time, he was managed with lymphedema with Uniboots, Ferro wraps, which is a Velcro compression wrap, although he has very poor compliance with these devices, and he was given lymphedema pumps. So what are our key diagnostics in this setting? Well, he has normal pulses bilaterally, so I don't have any contraindications or concerns with applying good, solid compression to him. He's had a venous duplex, there's no reflux, he's had a successful venous closure. So our other considerations is that he's not compliant with his compression, he's not compliant with his CPAP, and above and beyond all else, he sleeps in a chair. If you ask your patients with lower extremity swelling how many sleep in a chair, I will promise you, in cardiology it's about 25%, in the wound clinic it runs about 30%, sometimes more. And those that do not sleep in a chair will think you're crazy, but those that do see nothing wrong with it. It is perfectly acceptable to have your legs chronically dependent 24/7. So here's our clinical challenge. We have to control his weeping and his edema first. We need to get him in good compression, and I'm going to have to find some compression he's going to be able to use long term. I've asked him to increase his walking. He's not a very ambulatory man. He's fairly sedentary. I've asked him to sleep in bed and elevate the foot of the bed, and he needs to use his CPAP. So what we have is essentially that first level of lymphedema management or lymph or tissue fluid management, we are making way too much. We don't have lymphatic changes, so our lymphatics just can't keep up. But what do we have on the other side? Well, we have ongoing issues with his right-sided heart pressures, presumably because he's not using his CPAP. So I do need to know more about what's going on there. I need to be able to control that exudate that's coming across the endothelial membrane and control that tissue fluid weeping. We do that by compression, but I've also got to get him walking because I have no pump. I have no way to get all this fluid back up against gravity, short of getting him into bed at least part-time. And obviously, we're going to have to talk about compliance. So we had very slow ongoing improvement. We did put him in multi-layer compression, but then he got admitted to an outside hospital for acute respiratory failure. He was intubated. He was heavily diuresed while he was there. Obviously, he was flat in bed for a period of time, which helps. His CPAP was adjusted, and he came home using his CPAP. He's now maintained in compression. His legs were nicely decongested, and you can see what he looks like. This is a picture that I just saw him back in my office in follow-up. His legs are nicely decongested. He's got still the hemosiderin staining. He's got heavy atrophy blanche. This is what was weeping. I've never seen atrophy blanche that heavy over somebody's, the gaiter area of the shin. So ultimately, he really has venous hypertension and really just poor compliance. Now, the condition that he has really is more just chronic venous insufficiency, ambulatory venous hypertension. That's not to be confused with phlebolymphedema. This is one of our most common causes of secondary swelling at this point. It's that chronic venous hypertension with those secondary lymphedema changes. So now we have tissue fibrosis, we have swelling of the feet, we have squaring of the toes, and it's a little bit harder to manage because that fibrotic tissue is harder to compress and it's harder to get on top of this. All too commonly, it's bilateral. There are going to be very symmetrical changes. It may be a little bit asymmetrical with respect to the swelling because we can have additional disease. And this is essentially all of those things that contribute to venous hypertension, but now you've got that third phase of the lymphatics. You're making way too much, but because of the fibrosis and the ongoing injury and the chronic trauma, your lymphatics are impaired, and they can't keep up. They're not going to readjust very easily. Now, I want to move on and go through a few cases of unilateral edema. So we think about things a little bit differently when we have bilateral swelling. I'm thinking more of a central process, or it could be a central process or bilateral venous disease, et cetera. When you think about unilateral swelling, I'm thinking more of a quadrant disease. What's going on with a single limb, a single extremity, et cetera. So the first case is a 17-year-old lady. You can see that she's got left leg swelling. This was first noted about 2 years ago, and it followed relatively minor trauma with a sprained ankle. She's a gymnast. It's slowly progressing, no symptoms, but it has not gotten better in those 2 years. The next lady in the middle is a 36-year-old lady. She's had left lower extremity swelling since her last child. It doesn't change much through the day. It's pretty fixed. She may have some late-day aching. She doesn't really wear compression. She just notices that the leg is a problem. And then the third case is a 62-year-old man. You can see he's got right lower extremity swelling, and this started about 3 months ago. It kind of comes and goes. He's got good days and bad days. It feels tight. It's uncomfortable, but he hasn't had any, sores or ulcers or blisters or anything related to this. So again, if we think about this as a unilateral process, now we have to decide where are we going to image, where are we going to pay attention so that we can identify what the underlying etiology of this. It's unlikely to be a cardiac etiology. It may still be happening at the level of the endothelium. You can have unilateral endothelial injury. Certainly the calf muscle pump function can become very important in these patients. But we pay a lot more attention to what's going on the venous side of things, particularly in these individuals. So when I see these patients in the office, I always establish a working diagnosis. So for my first lady, I thought, well, could this just be lymphedema praecox that became uncovered, right? She had sort of subclinical lymphedema, and now we have that early onset lymphedema praecox. She could have secondary lymphedema from the trauma, although it really was relatively minor trauma. I don't think she has RSD or CRPS because she doesn't have any pain, and she doesn't complain of any other autonomic changes associated with. Our next lady could be a non-thrombotic iliac vein occlusion or Maythorner. We're going to hear a little more about that. She could just have varicose veins and chronic venous insufficiency, although you don't really see a lot of varicosities just on the images I've given you there. She certainly could have post-thrombotic syndrome because this happened after her last child, and it's not uncommon that we can miss a DVT. We do realize that many DVTs go undiagnosed. And in our last case, our 62-year-old man, he may have a subacute DVT. This happened 3 months ago, so we have to go back and figure out what else was going on. He could easily have post-thrombotic syndrome from a prior history of DVT. We do have to be at least somewhat concerned about extrinsic compression. When I have new onset edema that's very robust, it's not sort of slowly progressing over time, I worry, do we have something going on in the pelvis, or do we have to worry about, a prostate issue or something like that? And this could just be lymphatic congestion. He does have a little bit of swelling of his toes and the dorsum of his foot, as you can see. All right, I'm not moving. Okay, so what evaluations might be helpful? So now we talk about, do we need a duplex ultrasound? Should we do some pelvic imaging? How about lymphatic imaging? I don't do a lot of lymphatic imaging, but in some cases it may be helpful. So in our first lady, I would be plus minus on duplex ultrasound. This has been going on for 2 years. She doesn't have any varicose veins. She's 17 years old. So I think that if you did a duplex ultrasound, it's probably not incorrect, but I don't think it's going to be the highest of yield. I don't necessarily do pelvic imaging in these situations. She had very classic findings of a primary lymphedema, that of a little bit of changes on the dorsum of the foot, the toes are a bit squared, and a positive stemmer sign. We discussed lymphatic imaging. She elected not. We treated her very conservatively, and she's done well. In our second lady, again, duplex ultrasound may be helpful if we're looking for chronic changes. We're also looking for what the flow patterns are. Does she have any evidence of obstructive flow? Pelvic imaging, I think we're certainly going to progress to that. It may not be my first step. It depends on what I see on the duplex ultrasound. And I would not do lymphatic imaging in here. You can see that the toes are very well spared. The foot is spared. I don't think that this is going to be a secondary lymphedema of any sort. And in the last gentleman, I think duplex ultrasound may be our first start. Definitely because of that short onset, I would be inclined to go up and look at his pelvis. I don't want to miss, again, a tumor or something that might be concerning here. And I would probably not do lymphatic imaging until I look at everything else, if I did it even at that point. So what's our working diagnosis, and what were these ultimately diagnosed in these patients? Our first lady does have lymphedema praecox. We'll follow her long term. This can certainly get worse. Our second lady has a non-thrombotic iliac vein lesion, and we'll hear more about that. And our third gentleman had evidence of chronic changes on his venous duplex and has post-thrombotic syndrome that's just become unmasked. And I always tell these folks, I can't go back and tell you when you had your DVT, right? I can go back and look for a potential event or potential trigger, but I don't know when it happened if I just see chronic post-thrombotic changes within the vein itself. So our key learning points and things I want you to take home, think about form follows function. Think about the different things that you have to evaluate when you have bilateral disease versus unilateral disease, because they are different overall. Keep the differential broad and then narrow it down with your diagnostics as you go through. Work through the cardiac changes, the venous changes, the endothelial changes, the lymphatic function, and don't forget about functional impairment of the calf muscle. It is actually one of the more common things we see, particularly as folks age. I always get them up, I walk them in the halls, I want to see how well they're doing. Your evaluation may ultimately include a venous duplex ultrasound. It may include echocardiography. I have sent patients to right heart cath. Pelvic imaging, lymphatic imaging, again, I do that far less common. And then manage the comorbidities, manage the patient. You also have to manage the leg and the swelling, but you have to start with all of the pieces. It's not just diuresis, nor is it just compression, because I don't think that's going to get you or the patient where they want to be.
Thank you so much. Any questions from the audience for Dr. Carman? That was a fantastic talk. I have a question. So I think stressing the role of the calf pump is really critical and underappreciated, even the pedal pump, the foot pump. So my question is, when these patients, what are your thoughts on, we get a lot of other patients' physical therapy. Like, what's your experience doing that, or what are your thoughts on that? Oops.
So if I walk in the hallway and their gait is really bad, I do send them to physical therapy, just for gait training. Above and beyond that, what I will frequently do is explain to them the gait I need. I will coach them through exercises to strengthen and activate the calf muscle so they feel it. And I ask all my patients to get up and walk 3 minutes every hour. Most patients, if you tell them walk 30 minutes a day, they can't do it. But if you can get 3 minutes every hour over 8 hours or 10 hours or more during a day, you can start to get that same effect. So I do, and I ask them to do foot and ankle exercises if they're watching TV, every time a commercial comes on, every time they turn the page in a magazine or a book. So I give them resources, but I honestly send about 10% to physical therapy. Not much more than that. Good question.
What sort of lymphatic imaging or testing do you typically do?
Yeah, so the question is, what sort of lymphatic imaging or testing? I don't do a lot of MR lymphography, but I will do lymphoscintigraphy when I do lymphatic imaging. I don't do it often. Lymphoscintigraphy is actually fairly painful, so I don't do a ton of it, and I do it only if it's going to help me change what I do. I do a fair amount of referral to physical therapy for manual lymphatic drainage or complex decongestive therapy, even in my phlebolymphedema patients, to get on top of that lymphatic congestion. That's actually a really important part of the therapy.
Quick question. Is there a specific lymphatic pump that you prefer using over the others, or not really?
I won't say I have a specific pump that I prefer. Most insurances want you to start with a fairly simple pump and show that simple pump is doing an inadequate job getting you where you want to be before they'll move to a complex pump. So I do start usually with a simple pump. I do think a multi-chamber pump is probably preferred by patients as well as for clinical care over, a pump with fewer chambers. Good questions. Thank you.
Thank you.
Great, thank you.
Oh, well, let me introduce you.
There we go.
So next up, excuse me, our speaker, it's a pleasure to introduce Dr. Razavi, and he will be speaking to us on May-Thurner syndrome.
Well, thank you. What I'm going to do is I'm going to, instead of in the context of a case, I'm going to take a cautionary note on this entity, which is iliac vein compression. It's become in vogue that every time people see a little compression of the iliac vein, they stent it. Don't. Let's go over this. These are my disclosures. Epidemiology. Look, iliac vein compression is very common. Okay, you can see it in about, in the literature, about 20 to 30% of the patients walking around without any symptoms have iliac vein compression. Doesn't mean they all need the stents. So keep that in mind as we go forward. It can occur at multiple places. The left common iliac vein is the most common place we see it, but it can happen on the right side, a little bit lower, as you can see in the picture, and it can also happen in the left external iliac vein. If you put good IVUS in there, you can see these compressions, especially in the setting of DVT. Be conscious of those. So if these are 4 different patients, okay? And you can see 4 different venographic presentations. Which one needs the stenting? If I asked the audience that, what would you guys say? Well, that's a wrong question. The first question is, which one of these is symptomatic? And what are the symptoms? And are they due to this? And anytime you see an iliac vein compression, please follow the steps that Dr. Carman just mentioned. You have to establish that the symptoms are in fact likely due to compression of the vein rather than something else. As I mentioned, iliac vein compression is very common. Now, all four of these had edema. One of them has post-DVT, things of that sort. We'll get to that in a second. And the other thing is that venogram is probably not sufficient to establish that there is true compression or not. You need to have to use intravascular ultrasound, as you can see here. Those two patients are the same. You can see on the left side, there's no collaterals, there's no evidence of true compression, and yet when you put the IVUS in there, you can see severe compression at the level of the common iliac vein up at the top. In fact, in the venogram, you can see some synechia that suggests that this patient has true compression. Now, whether we treat this or not depends on the patient's symptoms, and it has to be established that it's due to that. All right. Indications for stent placement, really symptomatic obstruction. I keep coming back to that. Asymmetrical edema impacting quality of life, absence of other etiologies that Dr. Carman just mentioned. Really got to be C4 or more disease, okay? In presence of refractory chronic pelvic pain and venous reflux, possibly. It's becoming in vogue now. Again, everybody gets, the pelvic venous disease and pelvic congestion, and everybody wants to put a stent in there. You don't necessarily need it in all of them. This 50% obstruction that we all used to talk about is not going to get more than likely validated in rigorous studies. That is not sufficient. We need to retire that. So exercise caution. Having said that, you may say, well, look at the results of the pivotal trials in the Neville patients, May Thurner. They all look fantastic. They're all 95, 96% one-year patency. So what are you talking about? Exercise caution. The results are excellent. Well, I'd point to two things. One is it's not 100%, okay? About 5 or 6% thrombosis at 1 year, and that continues at about 2% per year. So if the symptom was not due to that iliac vein compression, then you have now put this patient at risk of continued 2 to 3 or 4% per year of obstruction and DVT. That's number one. Number two, just about every migrated and embolized stents that have been reported are in Neville patients. They're not in post-thrombotic patients. So that's why I say exercise caution. Now, how do you size it? Let's say we want to do this. A venogram is difficult to do because, the venograms are usually done in the AP projection, and the veins are elliptical and compressed. So what size should we be using it? Oversizing is bad, undersizing is even worse. So keep that in mind as we go forward. Obviously, we use nowadays intravascular ultrasound, and they're sophisticated enough that they can give you the diameter if you want also. Keep that in mind. The simple math that you could use is you take the longest dimension and the shortest dimension, add them divided by 2, and then add a millimeter or 2. That's how it was done in most of the trials, and that should be okay. Remember that you really don't want to put stents smaller than 14 millimeter in the common iliac vein, and certainly not smaller than 12 millimeter in the external iliac vein. So keep that in mind as you go forward. And also, if you're using Wallace stent, that behaves very differently than the Nightingale stent. So most people are using Nightingale stents nowadays. Also, when you're using IVUS, the other thing keep in mind is that the dimensions you get on the IVUS are perpendicular to the axis of the catheter. If you look at this, okay, you can see that the measurements at 2 places right there are very different, okay? So IVUS can overestimate the size of the vessel depending on the line of the wire, okay? If you're around the corners of curvatures, IVUS probably is oversizing, so keep that in mind, as in the arteries too, by the way. Okay? Now, in the arteries, it turns out in the lower leg is mostly sort of straight. In the veins, they're not. And if you're in the iliacs, you got those curvatures, IVUS can oversize slightly. So, technical consideration, stent length. Now, this is my pet peeve. And Neville's, by definition, are short lesions. The length of the common iliac vein obviously should be covered, but should the stent extend into the external iliac vein? Now, a lot of our colleagues, most of whom are my friends, and I respect them highly, wrote this paper that says that we should extend the stent in the Neville patients These are non-thrombotic patients into the external iliac vein. I completely disagree with that. What they're saying is that if you're stenting a patient who doesn't need it, anchor it into the external iliac vein so it doesn't move. That's what they're saying. But if the patient doesn't need it, don't stent the damn thing. If there is a real lesion there and you size the stent correctly, it's not going to move. I have personally stented common iliac vein over 1,000 patients probably over the past 30 years or so. We used to do this when people used to think it's blasphemy to touch the deep veins back in the 90s. But if you exercise caution and put them in the right patient, those stents are not going to move. Look at this patient. So that's the AP, and you can see the IVUS, complete compression. Here's the same patient in oblique. You can see now, appreciate the curvatures of those veins a little bit better. So we are going to stent this. The patient was symptomatic. In fact, this patient was post-DVT, and the DVT has been cleared, and you can see the compression of the iliac vein right there in the IVUS. Now, what we don't want to do, here's the common iliac vein, here's the external iliac vein. You don't want to end your stent into the curvature. I think we all agree with that, okay? So you either have to stent above it, or if you are going to end into the curvature, then come around into the external iliac vein. The problem of extending into the external iliac vein is several-fold. One is that it is more secure, okay? And that means that really in the patients who don't have a lesion, you want to anchor it in the external iliac vein. But it does create a diameter mismatch between the stent and the vein in the external iliac vein because you're sizing it to the common iliac vein, which is frequently 2 to 3 or more millimeter larger than the external. And it predisposes the patient to the Poisson effect, which means that you stretch the vein, especially in post-thrombotic patients, you compress the ends. This is well demonstrated here's one of our patients. As you can see, this is a post-thrombotic patient, and look what happened to the external iliac vein down below the stent. Here's another patient, post-DVT patient, that's compression of the external. We stented this, look what happened just below that. This is a well-established sort of phenomenon. We all see it. We used to think it's spasm. It's not spasm. It's that Poisson effect. And then now we get into this stent creep because you have to keep stenting down into the common femoral vein. Now, longitudinal foreshortening in response to the radial expansion leads to the collapse of the adjacent venous segments. So a couple of other things. Avoid doing this, extending into the other side, especially if you're using stents that are like wall stent, okay? They can compress and cause DVT on the other side. This is a paper from one of our colleagues, Aaron Murphy, who established this, and we all know that this can happen. Okay, and it's usually associated with the use of closed-cell braided stents. There are not that many of them in the market, but be cognizant of it. Here's a case of that you can see the opposite side is thrombosed, and the thrombus is extended into the stent and into the cava. Another word of caution: if you're stenting the confluence of the veins, please avoid double barreling the main channels, whether it's the IVC or the SVC. We do have IVC-size stents in the market that you can use that middle configuration, and that's the one you should be using it. Now, I'm guilty of having put at least hundreds of patients with that double barrel configuration and learned over time that is the wrong configuration and don't do it. And do the middle configuration. That's what you want to do. The right side is also not a good idea. Why? This could happen. You can see a lot of metal into the IVC, okay? Or this is, if you're lucky, it would look like that. Typically, it would look like this, that even if you use the same stent, one compresses the other, okay? Now you have to come back and open up that other lumen, create fenestration from one lumen into the other across those stents, and re-stent, and then a lot of metal into the IVC, which predisposes to thrombosis. So in conclusion, iliac venous compression is very common. almost a normal variant. Stenting of the venous compression should be done when the correlation of symptoms and the obstruction has been established with the protocol that Dr. Carman just mentioned. Please follow that in these patients and beware of the pitfalls. Now, I got 3 minutes. I'm going to show you a couple of cases, especially if you're doing chronic obstruction of the iliac veins. Beware of one other thing. Look at this. Now, this is open. This is not an obstructed case. This comes from Dr. Kankan. It's a great case, and I'll show you one of ours also. They're trying to put a dialysis catheter in the groin, okay? And this is their catheter. The other thing overlying is a peritoneal dialysis catheter. Immediately, you know that that catheter is lying way too midline for IVC. So they do a little, they can't get any flow. They do a little bit of contrast injection, and they see this. What is this? Anybody recognizes this? This is a myelogram. This is not a venogram. They are in the spine. The communications between the venous channels in the iliac veins and the small veins in the perispinal plexus are very common, as you can see in here. It is not that hard to traverse them into the epidural space. Okay, you can cause paraplegia doing that. Especially in chronic occlusions, be very cautious when you're doing that. Okay, go into the lateral. Make sure that you're not posterior to the spine when your wires are crossing. Okay, IVC is not posterior to the spine. IVC is anterior and lateral. Here's one of ours, chronic occlusion. One of my partners did this. Not that difficult to cross it, right? You can say, oh, push a wire right there, and that's what he did. Little bit of curvature in there, didn't notice it, and patient developed hemorrhage into the epidural space, okay? So be very careful. I'm gonna stop right there. Thank you.
Thank you.
Excellent presentation with lots of great tips. Any questions from the audience?
I just had one question. No, I'm sorry. How do you follow up on those patients where you put stents for Maytherner or iliac compression? And at what level of ISR do you proceed and do intervention irrespective of symptoms?
So two issues. The standard follow-up, it depends on whether they were Neville patients or post-thrombotic patients in terms of the follow-up and the ultrasound view. They're all followed with ultrasound. They're all followed at 3 months post-thrombotic patients because they are at risk early on for rethrombosis. At 3 months, 6 months, a year, and then yearly after that for 3 years, if they remain asymptomatic, then we just follow them symptomatically. Some of the trials followed them out to 5 years. They all cut back to 3 years because there was, the event rates were in low single digits between the years 3 and 5. In terms of in-stent obstruction, it is in-stent thrombosis. Truly, it's not neointimal hyperplasia in the veins. It's clot in the veins. We do that symptomatically. So if they develop symptoms, then we ultrasound them and then you do an intervention. The problem is that at that point, what do? We don't have a whole lot of devices, for in-stent thrombosis, especially when they become chronic. Now, there are some good devices in development. The one that's actually out there commercially doesn't work very well. And I'm just going to leave that alone as it is.
Thank you.
Dr. Carman, I think she had a question.
So let me ask a little bit of an esoteric question, but we think about these non-thrombotic iliac vein lesions in our younger patients, and that's typically when we have historically talked about them being present. But what I'm wondering is, because I see a fair amount of unilateral leg swelling, we go back, we look, I may have an old CT scan or something like that, and it looks like there's compression in our older folks. I'm wondering if anatomically, as patients age and they start to lose vertebral height, they lose their body height, do we have worsening of compression in some of these folks? Because I feel like I'm looking more in my 50-year-olds and my 60-year-olds now than I ever have, to be honest with you. Thoughts?
Yeah, I mean, we don't know because these patients are not followed that carefully longitudinally. We don't know the natural history well enough, but I can tell you that some of the older patients that we do see that we consider stenting, I ask them about their earlier symptoms. And some do say, yeah, this has been going on for a while, but this, that, and then they talk about teenage years and things, intermittent swelling. What we have seen in some of these patients, especially those who are hypertensive, because of the tortuosity of the iliac arteries, or if they get changes in dimension of the iliac arteries, we do see severity of compression. I've seen a handful of athletes where they get worse because the musculature and the iliac arteries get enlarged, especially cyclists. And I'm not sure what to do with them. We have been very careful not to overstent them. But if anybody has any other guidance, I'm all ears.
I guess just to your question, Dr. Carman, I'll just mention I've seen it on the other spectrum in the younger population, the pediatric population, where I forget which report, but earlier on, if you look at imaging, there seems to be like a stretch of the iliac vein and it mislabeled as a May-Thurner compression, and then over time as they age and their body develops and the anatomy changes to not have that compressive. So that's on the other end of the spectrum. But amazing conversation. Thank you so much. So we'll move on to our next speaker in the interest of time, Dr. Deeb, who's going to be talking to us about endovenous ablation.
Thank you for having me. I'm going to be talking about a 50-year-old gentleman with a large ulcer, not extremely deep though, and discoloration in his left leg. I asked this question to multiple IC people and vascular surgeons. What do you think is the most common cause of non-healing wound? And the answer was arterial disease. But in fact, it is venous insufficiency. It is the most common cause of non-healing wound in the lower extremity. If you look at really different trials and different, studies, it goes somewhere between 40 and 70% causes for venous ulcers. Now, for a lower extremity wound. Now, if you look at a venous ulcer and you compare it to an arterial ulcer, how do you know the difference? A venous ulcer is much more shallow, has irregular borders and margins, and has exudative base, as opposed to an arterial ulcer, which, as you can see here, is much more deep, has very regular margins, and usually occurs at the distal portion of the foot and the toes, or in the very distal edges of the extremities. Now, keep in mind, though, that there are patients who have both arterial and venous ulcers, and their workup is a little bit different. Now, second of all, you have to do physical examination. Consider in every patient you see an ABI and Doppler ultrasound. Consider doing venous mapping. Consider doing CT vein abdominal pelvis. And depending on the wound, maybe wound biopsy and culture, and those are things that the wound care will do and help us do that. But the most important portion of the entire workup is your history. History is the first and most important thing. How did this wound start? What happened? What led to it? Was it an arterial thing? Was it embolic? Are we looking at an autoimmune disease? What are we looking at exactly? And the history will tell you all those things. Now, when you have a mixed venous and arterial ulceration, you have a diabetic, obese patient who used to smoke, and you're starting to think, well, this guy could have both. Then you have to look at the ABI, and depending on whether your ABI is elevated, meaning above 0.7, or below 0.7, you start thinking, okay, if it's above 0.7, maybe I should start, fixing the venous compression therapy and the edema first. And if it is below 0.5, then maybe I need to improve the inflow first and then consider compression therapy second. Now, that said, I'm gonna jump into my case. It's a 50-year-old gentleman who came to me in July 2019. Had a very painful, very shallow ulcer, but extremely painful ulcer. He had swelling that started years ago and worsened in the last 4 to 5 months. And it was very itchy, so he was scratching his leg, and boom, the wound started. And this, most of the times, that's how the wound starts. You have a lot of itching, scratching, and you have a wound. Now, physical examination revealed great palpable pulses. Vein mapping showed incompetent right, left, deep venous, right, left, great saphenous, and tributaries of the left great saphenous feeding the ulcer. This is 2 or 3 weeks after wound care was taking care of him, and you can see that little ulcer over the ankle with a lot of swelling and hemosiderosis, a little bit of it. Now, this is our vein mapping. It's a little bit complex, but if you focus on the left side, you do see that great saphenous vein with significant reflux, and you see down there, there's a little blue line that shows the vein feeding the ulcer bed. And when you look at a quick mapping here, you see this kind of a GSV and multiple varicosities that come all the way up closer to the skin. And this is how an ulcer occurs. The venous ulcer really happens. You get a lot of venules just underneath the skin, causing a lot of increased pressure in that area. Now, the first thing I thought is we're going to have to ablate the great saphenous vein. I went ahead and did RF ablation to that area. Probably went from just below the knee all the way up to the groin area. And then we looked at it 2 days later, and the great saphenous vein was completely occluded, ablated. Now, then the question becomes, what are we going to do about those venules? Anytime you have an ulcer, this is really a typical case with a lot of venules under the ulcer bed. You have to scan under the ulcer bed. You have to see what's going on right there. So I went ahead and accessed caudal to those veins and performed varithena sclerotherapy. You gave around 4 to 5 cc's of varithena sclerotherapy, and you see that echogenic material going into the veins, and that's how you know that you really ablated most of those veins. He came back later, his veins were totally ablated, and his ulcer healed. Now the story gets a little bit more and more interesting. He comes back. I don't know, I've collected multiple times. Okay. He was lost to follow-up for 3 years and came back in 2023. Had a recurrent left ankle ulcer, and then the swelling has been worsening for at least 1 year, and the ulcer was noted 2 weeks ago. When he had the ulcer, he came back to see me in the office. So I repeated the vein mapping. I want to see, okay, where are we now? It's been 3 years since I did your previous ablations. And if you look at the vein mapping on the left again, you see reflux in that left great saphenous vein, but I'm like, no, hold on. I already ablated the left great saphenous vein. It can definitely come back and become patent again, but I'm not sure, and there are varices that they are noting around the groin area. And those are new. I haven't seen varices all the way up there. So I went ahead myself and rescanned him. And in fact, what I found is that those varices go all the way down and have a lot of reflux, but they are starting at the groin level, just below the common femoral vein. And the question is, why do we have those varices? His deep reflux is there, but it's really mild. Some people say 1.7 seconds is not much of a deep reflux, but it made me think that there is something more proximal going on. So I talked to him, and I'm like, okay, I prefer going now. I'm going to look at the deep system first and then go back to the superficial system. So we went ahead and did a venogram. And in fact, on the venogram, you can see maybe questionably a little bit of a left external iliac vein compression. And on the IVUS, you do see in one specific area significant fibrotic changes to the vein with more than 70% stenosis. We've all seen way worse than those, but this is what kind of explained likely what is going on in his specific case. And then after this compression that you see on the IVUS, it opens up and becomes more normal, more caudally. So I went ahead and did a stent into his iliac vein, and that was followed by an IVUS that showed great apposition and expansion of the stent throughout. And you can see the stent coming in right there. If I remember well, I used an 18 millimeter Abre in this case. He's a big gentleman. So, and his ulcer healed up completely after that. And then I repeated the mapping after the iliac vein stent was done. And now you can see that the great saphenous vein has been ablated. Those branches all shriveled up and really became very, very small and were not even seen at that point. A take-home message: history and physical examination are crucial in determining the cause of a leg ulcer. Venous insufficiency is the most common cause of a non-healing lower extremity wound. And venous disease is a dynamic process. You cannot just fix one thing and tell the patients your problem is solved. It's a very dynamic process, and it's very complex, and it involves really lymphatics, veins, superficial and deep. And you always have to think about differential while taking care of those patients. Thank you.
Okay, great. Well, lots of discussion can come from those cases for sure. So I just want to open it up to the audience and see if there are any questions for Dr. Deeb.
I have a question, Karem.
Yes.
Yeah. So, for a lot of you guys that treat both superficial and chronic, and deep disease overall, when you have patients like this that have combined disease, that have both superficial disease and have either non-thrombotic lesions, what do you try to address first? Do you try to address superficial disease versus a deep pelvic vein disease?
It's a good question. Usually if it's an ulcer in the lower extremity, I go with the superficial first. Definitely if you have a DVT, you don't, but if you have a superficial superficial ulcer, you go with the superficial system first, and you have to scan and do the vein mapping. In this case, if you remember, there were multiple veins, venules, under the ulcer bed emanating from that GSV that I've previously ablated. So when you see those, you can tell that the problem is that branch coming down under the skin causing that ulcer bed to occur. But definitely if you do that and still the problem is there, or the swelling's there, or the ulcer comes back, you have to think deep system, yeah.
The other question I have for you, which I've encountered a few times now, I don't do ablations, but with patients that you mentioned have combined arterial and venous insufficiency, it's very obvious that these are vein ulcers and not arterial ulcers. Are you approaching the veins first, take care of this, and then improve their circulation? Because we've had few of those.
I usually approach the veins first, but if your ABI is extremely low, you're worried about compression therapy.
Exactly.
And if you open the arteries, your swelling is going to get worse in your veins. So if your ABI is below 0.5, we're talking CLI kind of a patient, so I would approach the artery first. Okay. But anything above the 0.5 threshold of ABI, I do compression therapy, definitely not go very high on the compression, but with leg elevation and some compression and some form of venous ablation, depending on the case, before I do the arterial inflow disease.
Actually, I'd like to hear Dr. Carman's thoughts on this. I think it's very hard to get consistent compression in these patients, and I think 0.5 for me is like a little bit of a threshold. Maybe really think about which to address first. I think that's kind of a gray area, obviously. You have to look at the whole patient, individualized, but I think there's definitely variety of types of compression where you can control things a little better, consider the PAD patient, and again, how do you control for that?
So those are a lot of good questions, and I think to some extent it also matters how much swelling they have. So, while we'd like to heal most ulcers or many ulcers in multi-layer compression, sometimes we can't do that. So we'll use other devices. I will say when I'm down in that 0.5 range, that's not somebody I ask home care to help me with. I want that being done in my office with my nurses who put on, 50 wraps a week, as opposed to home care that does, 3 a week and doesn't necessarily know what they're looking for if somebody gets into trouble. You can tell pretty quickly if you're gonna get into trouble, if the ulcer's getting worse or if they have pain, they're not tolerating things. I always make sure when we do put them in wraps, we see them back within 3 days. So I know if things are better, worse, or staying the same. So I think you have to be thoughtful, you have to be cautious And you have to tell the patient what to look for, but you have to have good nurses so that they know what to look for. And they are sort of your, you know, your eyes and your ears when you're not in clinic seeing the patient every single day.
I have one more question. I think this could be for the panel together. So, well, first, I think there's a lot of debate, like you said, superficial versus deep, in which to do when you have both, right? And I think we're certainly more heightened awareness and heightened consideration for what to do when it becomes an ulcer patient. But when procedurally wise, technique wise, I think there are, I'm just curious to get the panel's opinions on what maneuvers you do to confirm if it's truly a compressive lesion versus just a positional dehydrated patient, even on the table. What are your approaches?
I'm not sure I understood the question. You mean?
Maneuvers, on-table maneuvers to confirm if that's truly a compressive fixed lesion.
So the question is it a fixed lesion or is it a pseudo lesion because of dehydration?
I mean, supine IVUS. So, I mean, IVUS is the gold standard. IVUS is the gold standard. Sorry.
No worries.
IVUS is the gold standard, but
Yeah.
it could mislead you on the table,
100%.
just like a CT scan. I mean, you're supine, you're dehydrated, and you're just looking at it from within instead of on a cross-sectional view. So what do you do to help you decide it's real?
I got you. So the one thing I always do, I do my vein patients in the afternoon. Reason is I get them in the hospital the morning of. We're talking naval lesions mostly. I get them in the hospital the morning of, and I give them a liter of fluids on that day, and I keep normal saline going in them. The second thing, when you look at the naval lesion, the vein is not normal on IVUS. You always have fibrotic changes to the vein wall when you look at it. If you see it just a normal, completely normal vein with some maybe some compression or some dynamic compression, this is probably just some dehydration with respiraphasic changes. But I always see on the true iliac vein compressions some fibrotic changes like you saw on this one within that area of compression. But that's what I do.
Yeah, the other thing is that you can have put the IVUS at the point of at the lesion and have the patient do Valsalva or cough, and you can see major changes in the dimension of the vein. We sometimes do a tilt table and have the patient cough or go Valsalva maneuver. One other trick that Steve Black uses, actually not a bad idea. He puts a 12 or 14 millimeter balloon in the external iliac vein and just pushes it across. If it easily crosses, probably there's no lesion there.
Yeah, and when we do Valsalva, I was going to mention that probably to maintain it, we put a syringe, remove the inner side and ask the patient to blow through a syringe so that you can maintain it for a longer time. So you can either do the pressures, see what's happening with the IVUS, and even if you want to do a pressure gradient or whatever, while they maintain Valsalva.
Yeah, those are great tips just for folks in the audience to consider. One additional thing I'll say is consider if it's an anesthetic under anesthesia patient, so an awake patient versus a sleep patient. An asleep patient will not use their abdominal muscles, accessory muscles, and so that's just all vent dependent, and so they get a bigger billowing, if you would, of the abdominal cavity from the thoracic pressure. Versus an awake patient who's bearing down and holding, you may see actually some worsening, especially at the external iliac vein in my experience, and that could mislead you to call it a compression, but that's really the abdominal wall pushing down. So, okay, some good tips. I guess I'm next. All right, so we'll move on to my talk. Okay, so thank you so much.
Yeah, Dr. Harth, thank you for being here. We're looking forward to hear your talk about mechanical therapy for acute DVT.
Okay, so, well, I think that Dr. Razavi will give a great overview of some of the techniques, and then I think that there's a lot of a need for new therapies, and we'll see, this will probably lead to some good discussion. All right, so these are my disclosures. So I'm going to present this case of a patient with in-stent thrombosis, because I think that's certainly a challenge that we face, especially when stents fail due to multiple reasons. And I think anatomically is certainly one of the things that should be considered, and we'll talk a little bit about that. So this is a 77-year-old female with rheumatoid arthritis with recurrent left leg DVT. She had a prior iliofemoral stenting. She said it was bilateral, even though she only had a left leg DVT history, so it's unclear why she got the right leg stented. This was about 10 years ago. At the time, again, she underwent thrombectomy of the left leg alone and was placed on apixaban. Well, 3 months prior to presenting to me, she came down with a GI illness. She was dehydrated, was hospitalized. For unclear reasons, her apixaban was dropped to prophylactic dose and never returned to her anticoagulation therapeutic dose, and ended up having left leg edema. This ultimately, in some delayed fashion, led to a DVT scan, which showed iliofemoral DVT on the left side in a side that was stented, although was not appreciated that she had venous stents at the time. And the management for that at that time was to increase her apixaban now to a therapeutic dose, and no intervention was considered or performed. So when she saw me, she had persistent edema, she was in significant pain, had what described as a tight band or tourniquet sensation in her leg, which was impairing some of her rehab. So she had a duplex, it showed occlusion, so we got her into the lab and took a really detailed look at the stent. And what we saw was that you could see here, let's see, left common iliac vein above top of the stent, distal stent, and in the kind of proximal stent. You can see that part of the stent is open. There starts to be trickle flow on the outflow, and then here you can see where the occlusion is. So there was a partial occlusion of the stent, and you could see that the inflow, so we start to look at inflow. When you get a duplex scan, you want to kind of see what the options are, try to understand why the stent failed. And we could see here that we have this monophasic or continuous flow pattern at the common femoral, or the inlet of the stent leading into the stent. And then I always want to know what's the options here, what is my inflow? And so we got confirmed that the profunda was open, and there was some femoral disease given her recurrent DVT. She also had a CT scan, so I like to get axial imaging in patients who have a history of stenting and other prior work. And so you could see that a couple of things. The left stent is misplaced. It's placed just shy of the compression or outflow portion where the iliac artery sits. And on the left side, it's certainly going into the femoral vein, common femoral vein past the inguinal ligament. But the problem with the right stent, if you look at the right stent, it ends at almost like a 90-degree junction. So we talk about placing stents at the curvature, which is a no stenting landing zone. But in this case, as the right side had a little bit of a turn, it also ended in a curvature spot. So that was a poorly placed stent on the right, and at least that side was not symptomatic. But now we have this challenging situation where the left stent goes towards the confluence, and if we're going to consider opening it up, I think this is where I start to consider strongly, the need to recreate the confluence, and we can certainly talk a little more about that. So here the challenge is, this patient's 77, she's comorbid, so you got to think about her comorbidities. These aren't short cases; these can be pretty complex cases, and also just going back to the importance of the cath pump, she's an elderly woman. I want to make sure, if I'm going to do all this work to open up the stent, I want to make sure she can keep things open by using her cath pump, staying mobile, staying active. It's not just a procedure that counts, or the anticoagulation is everything else that comes with it that's needed. Anatomically, the longer the stents are thrombosed, the more challenging they are. You want to consider inflow. If we're going to re-stent and open up the stent, do we have a good inflow to keep the new relining stents open? And I also consider the contralateral stenting for reasons mentioned, because if you extend just the left, you may end up jailing the right, and then you get into a whole other set of problems. So technically, we mentioned she had poorly placed stents from prior. And again, if you're going to reline, I think it's hard to reline stents unless you regain some of the lumen. I think stenting in chronically thrombosed stents, just because you get a wire through, I think that gives a poor starting point for the new stents, and it's really pretty fibrotic and hard to keep that open. So I had a long discussion with the patients prior to the intervention, the possibility of failure at the time of the attempt, and the possibility of she's already having repeat procedures, so the durability is not as great. So, and also her need for long-term anticoagulation. So with that, I just want to highlight some of the reasons stents thrombose. So missed inflow is probably the biggest reason. And when we look at the stent data, which was already mentioned, in the post-thrombotic patients, about 30% will have thrombosed at about a year. And it can be as high as 50% at 3 years. Nivel has low thrombosis rates at 1 year, as mentioned. And recently, this publication from 2025, which is really the first time we've had almost a description of an anatomic criteria, you could see that they've broken it down into 5 types of patients with occlusive disease. And type 1 is the Nivel patient, which has the best outcomes at 95% at 24 months. But you could see that as basically there's type 2, 3, which includes the common iliac, external iliac, down to the common femoral vein. And the patency rates are as low as 81%. You start to see a bit of a drop because you have more extension of the occlusive disease. But once you start to involve the profunda or the superficial femoral vein in type 4A and B, that's where we really start to see the drop in patency of stents. So here we start to drop to 60%. And if you have both involved, both vessels involved, that's a type 5. Patency is only 39%. So those are probably the patients that shouldn't undergo endovascular reconstruction. And then you really have to consider, strongly consider what's the role or the potential risks in patients with type 4A and B. And there are certainly other reasons for technical failure, including maldeployment, oversizing, undersizing, poor vessel prep at the time of the procedure, poor overlapping of the stents where they get dissociated, and also medical reasons such as compliance and hypercoagulability. And from a technique standpoint, in terms of how to approach these patients, I think this is just kind of my approach for access. And as you get more extent of thrombosis, I go from a 1-point access on the ipsilateral limb to a 3-point access, even when I'm doing stents. I think those patients can be quite challenging and not always very easy to approach just from a one-sided access point. So here, I'll describe this case, challenging case. We can talk about, some of the challenges with devices like Dr. Razavi mentioned in terms of their ability, who is the right patient with these new devices. I think we're, certainly in need of trying to figure out which patients these devices are going to work on, and sometimes it's hard to predict. But for this patient, particular patient, she had bilateral stents, occluded, partially occluded at least on the left. You could see her venogram on, to start off, you could see this was that common iliac point where it was open through some pelvic collaterals. The stent was thrombosed, and then this is the inflow. She obviously had some inflow disease. And so for me, before I start increasing my access points, I want to get through the stent. So I went from the ipsilateral popliteal heel vein, and once I was able to get my wire across, then I could actually proceed to try to open up the stent. So in these cases, the devices are not easy to use with just a single wire, meaning, or an unsupported wire. So I think body floss technique is highly critical in these cases. So I body floss the wire out the right jugular, and then I put a protrusive sheath because there's a lot of embolic material that can come at the time of opening the stent. So, and I wanted to do it from both sides to give me the most support for the work I'm going to do, because it is very hard to remove this material from the stents, and it's not always guaranteed to work, and you don't know until you try, is my early experience, I guess I'll say. So we placed a distal embolic protection with a protrusive sheath up top in the jugular, wired from the right common femoral additionally, and then body flossed them up out of the neck. So now I have full support. Suction thrombectomy in these cases I think don't really work. The material's highly collagenized. It's not acute thrombosis. So you really need mechanical therapy, and I think this is where you're able to clear more. And so I moved on to the RevCore device, which is the only device for in-stent thrombosis at the moment. And I think that we're certainly in the midst of seeing which patient this will work in. In this case, you could see some of the debris on the top right that we were able to get from the stent. And it's very hard, the more you get to the closer to the stent, I think that material has been there longer, and it's always harder to get that to clear. But we were able to restore flow, and then to proceed with further stenting, I addressed the inflow disease with another mechanical device, which is called a VenaCore, which is also available and a little earlier than I'd say than RevCore from an experience standpoint, but can do essentially a percutaneous endovenectomy as shown here on the bottom. This is what we were able to remove from that inflow disease area. So following that, now mind you, I'm kind of cutting the case into a summarized version, but I'm always doing IVUS before I start. I want to get a baseline, and then I IVUS at different stages throughout the case to make sure that I'm moving along in the right direction, or I can do directed mechanical thrombectomy based on my IVUS imaging, not just the venogram. But basically, we had a 50% outflow stenosis at baseline, and these are before doing anything. There was some stenosis at the stent at the common iliac on the outflow side. There was the portion that was clearly occluded and undersized, and then there was some inflow disease with a 78 millimeter diameter. The picture here in the bottom shows the stent. There was some where the stents were poorly overlapped, and there was the green is where one stent was going into the other, and the portion that was occluded. After mechanical thrombectomy, we were able to achieve about 40 to 56% regaining of the lumen at that area, and I thought this was good to proceed with relining. And so, I think this will be good for discussion in terms of techniques, but here I chose to double barrel both sides because when I measured with IVUS, I could not see any other good way to do this without having to jeopardize the right leg, and it was already a poorly placed 90-degree turns stent on the right. You could see here where that sort of abnormal landing of the stent is. So I prepped the vessel with balloon angioplasty for the stents, and then double barrel in with 14 millimeter stents, extending on the left to the common femoral vein, where we have now inflow. And here we see the completion venogram, and then on the bottom right images is where we started with on the inflow side. So here technical issues related to the failure was the stent separation, poorly prior landing, oversizing, and some inflow issues. So post-procedurally, we were switched her from to Lovenox, eventually made to apixaban. We dealt with some GI bleeding issues intermittently with no good source despite workup, and ultimately did get her to tolerate anticoagulation. And then on follow-up, her pain and edema is resolved with a Villalta score of 2. So some key learning points. Venous stent thrombosis is a very challenging problem to address. I think important to prepare. You got to get a good history. You want to understand how long these stents have been thrombosed. That gives you a sense of how challenging these may be. Certainly the exam, imaging, I like axial as well as venous duplex. These can be tedious cases, so patience is key, and two-team approaches are always better. As Dr. Castro knows, we've done some cases together. You want to consider the reasons for failure, inflow, mechanical, or medical, as these affect the options and approach and appropriateness to proceeding forward with another revision. I think technically what I've learned from these stent cases in particular is that body floss and full support are key. They let you get a little more aggressive with the stent because the material in there is not easy to remove, especially if it's chronic. You want to have a distal embolic protection. Mechanical thrombectomy, I think, currently is the best. I think suction doesn't give you a lot of good result. And then angioplasty, IVUS always, and address the reasons for failure. And post-procedurally, certainly medical management with anticoagulation and lymphedema management as well as ambulation. And with that, I'll stop. Thank you.
I'm going to say this is an extremely challenging case. Kudos to a very well done job. I was going to ask you this, just thinking technically about it. You went popliteal and you were able to put a retrieve. How did you do both at the same time while patient is prone? Or did you do the inflow first and then brought him back?
No, so that's a good question. So it depends on so if if the body habitus allows, I do them all supine, and I'll just get popliteal access with the leg out and frog leg position. So I'll have them elevated in that sense. Now, sometimes, so if they're obese or they've had a lot of leg edema, I will prone them, get access, and then go supine. But I like to do the case supine for the duration of the case. So that's my approach, yeah. Okay, all right. Let's move on. Okay, so now we have Dr. Deep again. He's gonna talk to us about chronic IVC occlusion.
All right, thank you for having me again. Now, those are my disclosures. This is a very difficult case, and I think I made it more difficult than it needs to be, but I work in the Dallas suburb, and I was called on a patient who is 40 years old from Northwest Arkansas. So being called from that far out, you know that this is gonna be a tough case. She had an occluded IVC in the setting of a previous CVT and IVC filter placement. She had a past medical history significant for cervical cancer in remission, morbid obesity, just as an answer to that popliteal and IJ thing. She was morbidly obese, DVT and PE. That was done in March 2024. She had multiple admissions for DVTs with medication noncompliance, and that medication noncompliance really hit me hard when I'm thinking about the plan for her, because if I'm gonna send her, I'm really worried about putting stents in this lady, and I decided ahead of time not to put stents. Now, 2 months prior to her presentation, she underwent a sternotomy for a suspicious mass in her anterior mediastinum. Following that, she refused to restart Eliquis, presented 2 weeks later with a large DVT, right and left lower extremity, underwent thrombectomy in February, and then was placed back on Eliquis. She continued to have pain, went to another hospital, again, underwent repeat angiography, attempt for thrombectomy. That was unsuccessful, and IVC was found to be, again, completely occluded. Now, the Doppler ultrasound shows extensive occlusive clot. If you follow with me here, from the right common all the way down to the popliteal vein on the right, and non-occlusive clot in the left common femoral vein. CTV abdomen pelvis shows large diffuse occlusive thrombus throughout the IVC, inferior to the filter, and diffusely throughout bilateral common iliac veins all the way down. If you look here on the left side, you see the right common femoral vein has no flow in it, and the left common femoral vein was barely compressible. So the question is, how would you approach this case? Again, the clot goes all the way down to the popliteal vein on the right. It's non-occlusive in the left common femoral vein, and the IVC seems to be occluded below the IVC filter. So thinking about all this, I thought maybe the best way to do it is to go prone popliteal vein axis to improve my inflow. I guess this is the most important part of the procedure. Go on the right and maybe on the left, but go on the right leg first, try to improve the inflow, open the flow, and then maybe bring her back and put her supine and take care of the rest. Thrombectomy was high on my differential for her. So that was the CT here. Okay, it's fine. Now, on the first day, I did a venogram through the right popliteal vein. You can see some clot up in the cranial part of the femoral vein. And on the second one, you see occluded right iliac vein up to the IVC. So just to make it short, I crossed into the IVC using multiple wires and support catheters. And then I did a thrombectomy using penumbra. And you can see the angiography here on the last slide coming up in a second. That shows that there is a trickle of flow above that IVC filter. There's not much going out of that IVC filter, despite all thrombectomy. And I put that catheter, you can see how far up I went. I put that catheter all the way into the IVC filter, but that clot is just not coming out. It is chronic, we know it from history, but I thought maybe I can get something out of it, but really nothing came out. So during the procedure, it wasn't easy because she was having an extreme, excruciating amount of pain. So anytime I put any catheter in the popliteal vein or move anything, she was screaming with pain. So At the same time, I recognize at the end of it that it's an outflow problem. The IVC filter is completely occluded. The IVC is completely thrombotic. If I don't improve my outflow, nothing will happen. I'm going to still be stuck. So my plan was to continue IV anticoagulation, bring her back the next day. Now, the next day I was not in the cath lab. I thought my colleagues might be able to do it, but they couldn't, and that was a Friday that next day. Saturday, Sunday happened, Monday happened, and then I came back on Tuesday. We could not fit her in the cath lab before then, and I had anesthesia at that point because she was really in a lot of pain. Now, on day 5, here's the situation. We came back to where we were. She had reclotted, definitely at this point it's acute, reclotted the right leg all the way down, and the left leg is still the same, and everything, she's back to baseline basically. So what would you do now? So again, the clot is all the way down to the mid-femoral vein, and the common femoral vein is kind of compressive, so we can go through it if needed. I decided to go through the left common femoral vein, which is kind of compressive and not full of clot, and put her supine and go from there. Here's what I did. Went in the left common femoral vein, did thrombectomy again using the penumbra catheter. This is the penumbra here moving, and then I did an angiogram that again shows that the IVC is occluded, because again, even though I went all the way up to the IVC filter, I could not get that chronic clot out. Following that, I need to improve my right-sided inflow. So the best thing I could do is to go up and over from the left to the right, and again do a penumbra thrombectomy from the left to the right, and I cleaned out the right leg from up and over axis. After that was done, I went ahead, IJ, went down to the IVC, took a shot of the IVC, and as you can tell, it's occluded. Unfortunately, I did not save the IVC filter retrieval, but I did put a Protrieve because you have to protect from any PE during those procedures. So I did put a Protrieve sheath, and through the Protrieve, I put in another 18-French sheath and went down, and I was able to snare that filter that you see here, and I was able to take it out. This is the amount of clot I got from the right side and from the IVC itself. Now, as I told you at the beginning, this lady has a significant history of multiple admissions with non-compliance, so I was very worried, honestly, about putting stents in her. So the plan that I did was to go ahead with continued thrombectomy, and after that, do a balloon angioplasty using 16-millimeter balloon here to the IVC, and to try to get the best flow out of that IVC as much as possible. I hope this will come soon. But this is my balloon here in the middle scheme showing how the IVC is being dilated. And I did multiple IVUS runs and multiple penumbra thrombectomies at the same time while doing all this. So once I got that, I thought, okay, I'm going to stop here. I got a decent outflow. Inflow is decent enough from a procedural perspective. And then I wanted to put her on Lovenox and bring her back a month later for reassessment and possibly go back in and see what is left, provided she is being compliant, and consider stenting in that time and follow up with hematology. Unfortunately, she did not come back. And I tried to follow up with her and call her, but again, her phone numbers were not functional. So I guess that, to my understanding, from the time we did the procedure till 3 days later when she was discharged, she was doing much better from a pain perspective. Thank you.
The big question is, and probably the panel can get involved, if that you have a patient who's non-compliant, one of the problems I have is that if I am convinced that the patient is non-compliant, I don't even start the procedure. Because whatever we do at the other end, you're going to have the patient's cooperation to make sure that the outcome is good. I mean, this is, by the way, is not that easy. Great job there. But if the patient is non-compliant, the question is, should we even start?
I was hoping in this case that she would become compliant after all the pain she went through, because the amount of pain and screaming that I had in the cath lab was really, really bad. And I tried to emphasize as much as possible. I spent enough time with her. Again, you can only hope, but her leg was really, really bad at the beginning. I just couldn't not do anything.
So I did a couple of cases like this, pretty extensive. We had to use angiovac when we removed the filter and all the way down. And also without stenting had very good results. But do you really need to go popliteal is my question, because in these cases, I did bilateral femoral through the clot as low as I can get and did the angiovac from the neck all the way down to that area, cleaned it up. And usually people do, I mean, patients, at least in my experience, not a lot of patients, obviously nobody does a lot of these, do a lot even if you don't go all the way and clean up the popliteal or put anything, you know. So do you really have to put them on their belly and get popliteal? I just do low femoral access and clean it up.
No, I wish I didn't. But the truth, you want to clean up to that profunda area.
Yeah.
So if you can go from IJ all the way, I couldn't because the IVC is completely occluded in this case, but if you can go all the way retrograde, venous-wise, and clean that area where the profunda, you have a decent inflow, I think that would be enough. But I just wasn't sure I'm able to do that from the get-go, yeah.
I think it depends on the anatomy. You know, some patients, you may have clear outflow, but if you don't have good inflow, that may also cause problems too. Like we've seen in patients if they have significant, fem-pop disease, which in a lot of cases we'll just manage with anticoagulation alone. So I think it all depends on the anatomy. But, sometimes if I've tried to just do a, high femoral stick, sometimes I realize my sheath is too, higher than I actually wanted it to be. So I'm kicking myself, I'm like, oh, I should have just done pop access. So I try as much as possible to frog the leg and get popliteal access when they're supine. And, unless they're two of severe LVs, more often than not, I can do it. But I'm often hitting myself when I just try to do femoral, high femoral, low femoral versus popliteal axis.
I'll say, inflow can't be underestimated or understated as, you have to kind of really understand that's the main reason for these failures. And I think when looking at profunda, I think it's easier said than done. I think oftentimes you can get confused with the circumflex, because there's a lot of other branches you may see reflux back, and so you may call that profunda, but it's not truly profunda vein, and then you think you have inflow, and then you don't. And I think sometimes it's hard to get a really good duplex, especially if it's at night or whatnot. But in that case, I think what I've experienced in the staging process, because clearly, like maybe if you had the timing, with all the scheduling stuff would have worked, you would have stayed open, but in a patient who has, some of these patients have one opportunity to open them up. So let's say the anticoagulation compliance is all on board and it's perfect, they're going to be compliant. If it needs a stent, I think, and you're hesitant to stent, well, first decide that you really need a stent, but and then if you realize there's a lesion, I think it's best to stent up front, because what I've been burned with, I guess, in sense of that the patient actually has done worse. They've rethrombosed, and that second hit is almost worse than the first hit. And the veins are more damaged, and then you lose the inflow that you maybe had the first time around, and then you're really left with an even less desirable anatomic candidate from a stenting standpoint. So I think those are the cases that stick out to me when I've sort of missed that opportunity on the beginning. And then, so I'll say that.
Can I ask one question? I know we're short on time, and I won't say that I've done this commonly with any of my vascular surgery colleagues, but in a few patients where there's less than optimal outcomes and/or we have anticoagulation issues, we've had opportunities where they've created a small AV fistula that keeps the veins open, because now you've got reasonable, high flow. Do you ever consider that in these settings? I mean, clearly those can close if they're, small enough, but do you ever consider this? I haven't done this in many years, but we certainly have.
There's a paper by Human Jalai that they did compared their experience of endovenectomy in the common femoral vein outflow stenting associated with fistula versus just stenting alone, and the outcomes were the same. And so they have now abandoned the endovenectomy of the common femoral vein associated and the AV fistula. that doesn't mean that in these situations that won't help. The only other thing I would have done in this case, obviously you did a great job. I probably would have stented it to at least get the flow going, and knowing full well that we now have predisposed this patient, if she's non-compliant, to pulmonary embolism. But at least the chances of thrombosis of the IVC and the iliac veins in the setting of good flow with the stents is less than leaving disease behind.
Excellent. Thank you. Great conversation. We're going to move on to our final talk by Dr. Hammad, who's in the crowd, and he'll be speaking to us about difficult IVC filter retrieval.
Okay, awesome. Thank you. Okay, great. So I'm going to start with my case. I'll try to be quick so we make it to the break on time. Oh. Okay, no disclosures. Okay, so this was a 74-year-old man who had GI bleed and DVT in the same setting. So he was, given an IVC filter. This was September 2020. He was seen a year later in the one of our vascular medicine colleagues in the office, and they recognized that he was back in anticoagulation, able to tolerate it. So the decision was to actually refer him to me for IVC filter retrieval. Pertinent history, as you know, the DVT has one other indication for anticoagulation, which is the AFib. He's tolerating it well, no bleeding issues. And per report, he got Opti's retrieval filters. I think it's very important to know what type of filter because it affects the approach. And some of them not retrievable, some of them are. Most of the new generation are for the last 10, 20 years. But this filter specifically, you can place it either way, IG or femoral, but you can only take it out femoral because the hook is down caudal. Okay, so this is, I took him to the cath lab in November of 2021. I think I was only 3 months into my attending life. And I got this, I got femoral access, right femoral, and I got a venogram, and, you can see that the filter looks like, it's hard to say in this, middle panel, but looks like a little bit tilted, and maybe the hook is outside, penetrated the IVC wall. But it's a little bit hard to say. So I tried to snare it using, regular kit we use, and, I'm barely getting close to it. Any thoughts here from the panel?
Yeah, this is a nice embolization device for IVC, and it looks like an embolization device. No disrespect to the manufacturer, but this device needs to be removed from the market. You're approaching this obviously correctly if you have to remove it. This needs to be approached from both the jugular and the femoral and stretched and removed, yeah.
No, the filter's patent. He's going to be on anticoagulation.
You have a point.
I would not take this out.
Okay. You have a point, but as you know, there is an FDA warning in 2014 because of the complication filter, migration, embolization, penetration, a lot of complication, thrombosis itself. So I think there was an FDA warning that these filters need to be removed, as soon as possible within 30, 60 days. Now this filter is a year old, which I think probably made it, that tilted and that kind of, penetrated.
This device may fracture, but it's not going to migrate.
This doesn't migrate.
You're right, because
this
the
is
barbs
associated with thrombosis, and it can penetrate, but it also gets really ground into the wall. And I don't take these out. When they've been in more than about 3 months, I don't even consider them. I
The
just tell the
IFU on
patient
this,
they're yours.
The IFU on this device is to remove it within 2 weeks. This is, I think we all hate this filter without naming it, but this is probably one of the, and most difficult because for some reason it just dwells into the wall of the IVC. You could see, I'm surprised after 1 year, this one is almost all within where the luminogram is. Most of the time you see it outside the luminogram.
If you need to remove these devices, they can be removed. Actually, they're not that difficult. But Dr. Carmen's point is a good one that should you. So let's see how you did it.
Yeah. Great. So I think I agree, 100% agree. It's a risk benefit. These patients under moderate sedation, I'm very careful. I give it an attempt. If I can, I just give up, or I give it to somebody more expert like Dr. Harth, who does way more complex retrievals. Everybody knows this can be either a 1-minute case or a 2-hour case, most of the time. So I've tried different maneuver. I'm not going to go through now for the sake of time. But bottom line, I ended up using this is just to show that's truly out the IVC wall and it penetrated. And I ended up using rigid bronchoscopy forceps. And I was only 3 months into fellowship, and honestly, I was not trained on that. But I've seen one of my IR colleagues, because where I work, we share the cath lab with IR. And the tech actually suggested, I said, you know what, I'm going to do it. I'm going to do it very careful. So I upgraded to 14 French sheath. I grabbed it with the forceps. And what I do normally, I tug on it just to make sure that patient doesn't have any pain, belly, abdominal, back, etc. And then I move it right and left. And once I know there is zero pain, then I feel comfortable. Normally speaking, honestly, I probably should have released it and then snared it the normal way. But I felt I had very good grab at and coaxial, so I decided to remove it. And we removed the filter. We took post-venogram. Everything went very well. Okay. So this was the resolution of the challenge, but actually it became a challenge for me because I have used this forceps total of 4 times. And I think 2 of them failed, and they referred Dr. Harth, and she was able to elegantly take these filters out. And I think one of the key, probably general anesthesia. I don't. I'm a little bit fearful. I want to make sure that I know if the patient has any pain. I don't use general anesthesia, so I'm a little bit fearful. So this filter, this forceps, even though it helped me, it became a challenge itself. So so this is just a stepwise approach I use as a cath lab when I retrieve this filter. So you see in the left side panel, the first panel, I use sometimes just different snare, and this may help. Second panel, I try to use a GR, which will give me more directionability, so I can reach where the, if the hook is, if the filter is tilted and the hook is, somewhere else, extreme angles, and I use a GR just to help me, and I put the snare through the GR to help me go certain direction. Third panel, sometimes I use an IM or SAS cutter to go around the filter. This can be dangerous, depend where your wire goes under. If it goes under the legs, you can fracture, embolize it, so you have to be extremely careful. I don't like it, this maneuver. And the fourth, of course, I use the forceps, which again, I failed 2 times, succeeded 2 times. I give it a try and make sure no pain. I don't go aggressive. And like Dr. Carman said, risk and benefit. If that first case, within 2 minutes, I was able to take it out. If I try more than 5-10 minutes, some pain, I just give up. I'm done. So what actually came, the resolution became, as we cardiologists, we do cardiac biopsies, and we use a cardiac bioptome. And those are way less, aggressive. First of all, they're not rigid. They're very, flexible. We take cardiac biopsy from the very thin-walled RV. So you can imagine with using this device, and we don't perf the RV. So these are very kind of low profile compared to the rigid bronchoscopy. I think the only thing to their disadvantage, they're flexible, so they don't give you that support. Plus, you cannot, even though you can shape it, it's a PTFE sheath at the end of that, bioptome. You can shape it, but it loses its shape and becomes hard to direct a certain way or another. So actually, what I've been using to give it directionability and more support, I've been using angled 12 French sheath Ansel. This filter only, this forceps only need a 7 French sheath. It comes in 2 different sizes, 5.5 and 7, and 2 different lengths. I think 50, and I think the other one maybe 110. But the reason I use 12 French because I tried using the routine retrieval kit, which is 11 French, so I just upgrade, put a 12 French. But this filter can go through, this forceps, can go through a 7 French sheath. So this is a case, and actually this filter you can also, I keep saying filter. This forceps you can rotate the jaws itself, so the jaws you can rotate it. And then I use the Ansel sheath, the angled sheath. I turn it from the outside, right and left, so I use it to torque it where I want to go. So it helped me put the forceps jaws where I need to be. So this is just one case to illustrate how this is being done, and the same maneuver once I get a hold. Ideally, I want to get the hook or right below the hook, that, a thick portion, and I tug on it, back and forth, about 1 or 2 millimeter, and the right and left, and patient has no pain, then I just retrieve it. And ideally, again, you should be maybe just release it and snare it the normal way. But if I feel like, okay, I got a good grab, I'm coaxial, it's not going to give trouble, then I honestly sheath it halfway and then pull the filter out. So key learning for me, know the type of the filter and how long it has been. So you can be prepared what you're going to get yourself into. Always get a venogram at baseline after removal to make sure no complication, and think out of the box while outweighing the risk and benefit. And if you have done so aggressive maneuvers, make sure you count the legs once the filter is retrieved. And if maybe one is missing, then we have to X-ray the lungs, the heart, maybe somewhere else. So have a backup plan. Okay, thank you so much. Any questions.
Well, one of the things you could use the forceps for if you have a difficult filter retrieval, and that's when the hook is actually in the wall and endothelialized, is actually use the forceps to remove the tissue, and then you can and release the hook so you can snare it, and the forceps that you use that are used for biopsy are perfect for that. That you can remove that tissue around the hook and release it so you can easily snare it and remove it in the standard fashion. Also, the non-flexible forceps are easier to introduce through the jugular than the groin, and you did a great job on that first one that you just used one access and removed it. It was a left access, so kudos to you.
You're absolutely correct. The other two times I failed, it was just the patient. Once you put that rigid, forceps in their neck to their body, just they cannot tolerate. They have pain. It's just very rigid.
We sterilize these forceps and put curves on them that fit this application, and we keep them on our shelf rather than go to the operating room, which they usually end up, and then it's hard to find them. That particular curve that you put on it, so you can remove them, remove the filters that need to be.
Okay, awesome. Thank you so much. Thank you.
That's awesome. All right, and that brings our session to a close. Thank you so much for sticking around. We'll let everybody move along to their break, and I'd like to thank the panelists and my co-moderator and the speakers for a great session. Thank you so much.